Okay, so we're going to go ahead and get started with our afternoon session now. So this is the time where we're going to go back to that interactive and try and look and see what everyone's responses were after our day and a half of meeting time. So just as a reminder, we're not going to go through all of the individual responses that got submitted, but we're going to try and give everyone a feel for where things have evolved over the last couple of days. And so Jyoti and I are going to be tag teaming going through your results for both the interactive and the barriers and opportunities questions. And so I'll start it off with Jyoti.
Okay, great. So the first question we asked was what you consider yourself as. So we received a total of 46 responses. So here is just a distribution of attendees in the room. So most identified themselves as researchers, and then we have clinicians or healthcare provider, educator, and
Jyoti,
other.
It's actually quite difficult to read, so if you could say which bar is.
Oh, yes. Okay, so the top bar is clinician healthcare provider. The second bar is educator. The third bar is patient participant. The fourth bar is researcher. And the last bar is other. Thank you.
You got slides? Okay. So then we had a series of questions where we asked people to be able to let us know what you thought was the number one different types of research that could potentially be done by NHGRI to be able to use genomics for medicine and health in the next 5 to 10 years. And so the first question was asking, what is the number one foundational resource that is needed for genomics to be used in medicine and health for the next 5 to 10 years? And you'll notice here a couple of themes that were coming up. One of them is this idea of databases. So a lot of the ideas that were put in here as foundational resources were databases that were doing things such as collecting information about utility and phenotypes and integrating them and trying to come up with tools to be able to look at variants and link them to clinical care and how can this information be used in the clinic. So those were a lot of the types of data that came up under foundational resources. Another major theme of the results that we saw was related to this idea of looking at populations and public health. So that's really something that came up over the last couple of days, was trying to think about not just a more traditional academic medical care setting, but trying to move from this idea of thinking about using genomics for reaching a diagnosis to thinking more about preventative medicine and how could this be used to be able to look at public health and more preemptive testing. And then finally, another tool that really came up in this was this idea of the infrastructure and repositories and support was another theme that kind of came up in a number of these responses that we also saw a lot of on day one. So any comments or questions related to the foundational resources? Yes, in the back.
As my friend Dan just reminded me, this very much sounds like the All of Us research program.
Mm-hmm. Any other comments there? Yes.
Yeah, I'd say that what is not like the All of Us research program is that All of Us has no way to look at the implementation of genomics into medical care and how it's used to change people's lives, and that is critically needed information.
I would also note that a lot of these questions, though, the database aspect of this and reaching out to populations does sound a lot like All of Us. A lot of them were focused on trying to be able to link that information to care decision making and how do you build a database that has that kind of clinical utility type information built into it to be able to have it used for being able to help with decision support. Any other comments from the audience regarding the responses around foundational activities? Okay, then we can move on to our next question, which was then to ask about the number one barrier to implementing genomics in medicine and health in the next 5 to 10 years. And similar to when we did the barriers and opportunities activity on day one, you'll also notice that here the top word was around lack. So pretty much everything that you find around there is related to what people were seeing as being a lack of. So here, one of the things that came up was there was a lot more related to thinking about population research again, as well as thinking about education and knowledge. And this idea of being able to really include lots of individuals in the discussion process, this idea of including the public in being able to come up with both research questions as well as the value and the types of information that should be returned in different types of clinical settings was coming up in a number of these responses, and seeing it as being a barrier to being able to have inclusion of all of these populations. So any comments from the audience regarding the barriers that we have to overcome? Okay. So then our next question was to look at aspirational research projects that could help to improve genomics use in medicine. And so here we once again see that idea around implementation in the clinic, as well as the idea of really trying to move beyond purely looking at a disease phenotype and diagnosis into the idea of screening and thinking about the population health. And so once again, we're really seeing that as this theme that's emerging from these days of discussion, is moving from more of just evaluating evidence to being able to make diagnoses towards more of being able to use this information in broader health. Any comments from the audience around aspirational research projects? Yes, Dan.
As I reflect on what we've been talking about in the last day and a half, one of the things that feels like it's missing is sort of discovery science in genomics. We're talking a lot about implementation, we're talking a lot about generating large data sets, we're talking a lot about those things, but actually sort of discovering disease mechanisms and discovering why variants confer variant function on the proteins that they encode. Those are the kinds of things that are missing. So for example, one aspirational project might be to functionally characterize every single possible nucleotide substitution in the coding region across the genome. And that's I'm sure that you've heard that kind of thing before, but that's a dictionary, that's a catalog. And then the next question is, why do some of the variants do what they do, and why do others don't? I don't hear a lot about the discovery science, the why, the mechanisms.
Yeah, and so part of that is the way that this meeting was structured. So this workshop was to be very focused on more of the implementation side of clinical use of genomics, with the understanding that we have had some other meetings to be able to focus on more of the discovery-based side of genomic sciences and how would you build those databases then to be used in the clinic. But I think it's definitely worth exploring, how do we need to be able to set up to be able to utilize that information that might be generated around variants in a clinical setting. Carolyn?
Well, but I also think related to that is what is and this is a little bit of the question I asked the knowledge base group at the end yesterday, what are the actual types of data? I mean, you can do genetic databases can be of many types and many things. What are the types of specific data that would be most valuable to this group? And there's lots of things that we can generate to understand biological understanding, but currently, or looking in the next 5 to 10 years, in terms of clinical applications, what is it that you want in a database or a knowledge base that that would be particularly valuable? And then for some of those things, I think like Katrina said, penetrance, like what. We can think of multiple ways to go about that. What type of thing would be useful? And I'm just using that as an example. I think drilling down on that from this group's perspective is not something that we've done previously.
Yeah, so we've got Mark in the back.
In the spirit of shameless self-promotion, I will reflect back on my opening talk, which is the idea that we have to have a virtuous cycle between the implementation and clinic and the discovery, and it's really only through creating that sort of a cycle of knowledge that passes back and forth seamlessly, will we be able to optimize our learning? So I think Dan's comment is cogent in that perspective, but just needed the contextualization of how do we enhance that communication.
So does anyone have any ideas they would want to share about projects or ways that we might want to think about that more learning health system, or data that we would want to be able to have available in that type of system?
Well, so I could imagine, and I think, I can't remember now who made the comment about, maybe it was you about the variance of uncertain significance when you were talking about this, is that as we develop sequences that are tied to clinical data, we can certainly mine those for pathogenic variants that we can use to return, but we can also use that information to explore other phenotypes that may be less obvious than the sort of the phenotype that we think about, that's whole iceberg phenomena, but also the idea that there are going to be variants that are in certain parts of the protein in that may create a very different phenotype that could inform additional discovery about function or that. And so I think those are the sorts of projects, just exploring the full range of variation in a population with clinical data that could be highly useful.
Yeah, thanks for the acknowledgement on that, but I'd like to draw attention to Lisa Bastarash's phenotype risk score as well as another complementary approach to that.
Thanks, I think Katrina?
Yeah, for penetrance, I think there are several different ways we can go about it. Thinking about one step in the right direction is taking relatives of the individuals who came to clinical attention and starting there as a way to try to get enough cases to look at phenotype in those individuals. We can look at people who have secondary findings, and I think in some respects we're going to need to go back and re-phenotype those individuals because they will not necessarily have the measurements that we need in order to assess whether the phenotype is present or not, because they're not currently clinically symptomatic. So I think those are some examples of the kinds of designs that we could think about, but really the challenge is going to be figuring out how to do that in a really efficient way, as well as pulling together the cases that we need across a broad range of institutions and organizations, and building the collaborative relationships to do that. In terms of looking at the effectiveness of the interventions, which is another piece of data that I think we really need in order to be able to justify doing population screening, for instance. There is just such a lack of information. It's so surprising in terms of the interventions that we think about for some of these conditions. And I think we really need to, again, try to figure out how are we going to pull together enough individuals with the same condition and looking at those interventions and seeing what happens to those individuals in terms of mortality in particular. So I think those are really challenging kinds of studies to do, but we really need to work together as a whole community to make that happen.
Yeah, Juan?
So I think in terms of aspirational projects, I mean, what I would like to see, and we can have the discussion of whether or not we're ready for this, or is sort of a very simple, high school science fair project type thing where, let's say you have 1 million people, 500,000 of them you have genomic data, and every time they go to the doctor, that genomic data is incorporated into their care, and then you have 500,000 people where there's no genetic data and it's not incorporated into research, which is the way it is right now, so status quo. And you can measure over 5 to 10 years the outcomes and see if there is an actual benefit to having that genomic data. And I don't know if someone's already done this and we're already ready to just scale it out, or if we're not ready for that yet.
And I think that is an idea as well that we did hear come up a little bit earlier today, where people were talking about needing to have measures and ways of determining outcomes that could be shared across studies so that you could start looking at some of this information as well across larger populations and being able to compare some of those outcomes from doing different types of genomic medicine research. Heidi?
So kind of following on Katrina's comment and Carolyn's around knowledge bases, one of the things that inhibits the therapeutics development is they really need to understand the natural history of disease, when they can intervene, where they're going to be able to show actual changes in outcomes. And so having a database that is an aggregate of individual phenotypes that can be publicly accessed online, so you could, for any disease, define the spectrum of phenotypic features, the age of onset that those features have started, would, I think, and the prevalence of that disease in the population, would really, I think, aid not only, a variety of research endeavors, but certainly therapeutic development and opportunities, and also patient care, frankly. Because, patient wants to know, am I going to develop these other features? And if so, when? And in terms of caring for that patient. And I think a good prototype for this is the Decipher database in the UK. Helen Firth and Matt Hurls have developed this off of their DDD project. Now it's fairly focused on neurodevelopmental phenotypes, but I think taking a look at that, which is really basically a public interface to a deep case level database that is incredibly useful to the community. I use it all the time. I think is something to think about that could expand beyond just the DDD project.
So that sounds a little bit like trying to take what's been done for some of these rare disease databases, which have lots of information about phenotype and the genetic information and longitudinally kept over time and what's happened in outcomes, and trying to expand that more broadly to the entire population and looking across different disease entities. Mm-hmm. Yeah. Is it Dustin?
Can I just endorse that completely? I mean, I think that's an awesome idea. I think ClinVar is such a fantastic resource right now. It's a little messy. The ClinGen curation effort is phenomenal, helping clean that up a little bit and provide expert level recommendations. And now I think this idea that was just presented could be even better than the ClinGen curation with more rich phenotypic information. So I think that's phenomenal.
Any other ideas that people want to bring up around this idea of research? Yes, please, Malai.
So something to think of might be, we have health information exchanges. They are mostly regional, or they are based off of a EHR provider. Like, for example, Epic has its own HIE, as does Cerner. So to build these knowledge bases, maybe we can use that foundation that's already there with the health information exchanges and try to have a national one where the data from these health information exchanges goes to a more national one.
So trying to find ways to federate data across different existing databases by establishing some sort of standard or that we can use for sharing that information.
Correct. And an extension of this would be to have a common data model for representing genomic data. That's where groups like HL7 are trying to do work, and they are trying to create a common data model. So if we had a common data model and we can capitalize on some of these exchanges, we could actually try to build these knowledge sources.
Thanks. Any other ideas people wanted to bring up in this category? Yes, Mark.
Yeah, the standards and data model issue is important, but messy. You know, the nice thing about standards is there's so many of them to choose from. But I think there is a way forward that that NIH and NHGRI in particular has utilized, which is you can be a de facto change agent in terms of what is utilized, and the example of that is OMOP, where this appears to be a very useful model to federate phenotypic data across electronic health record systems. And as we develop more experience with it in a variety of research projects funded by NHGRI, it became evident that this was a really good solution. And as a consequence then, in subsequent funding announcements, the requirement has been and you need to be able to represent your data using the OMOP standard. And so while OMOP may not necessarily become a clinical standard, it could become a research standard. PROMIS is another example that was discussed earlier. But it does require some reflection about what would be the most appropriate way to do it. But if we have that in place, at least from the perspective of genomic research, it makes it much easier to aggregate results across multiple projects.
Thanks, Mark. Okay, so I think Dan will give you the last comment, and then we're going to move on to the next question.
So this is an idea that Lisa Bastarash floated to me over at drinks last night, so I'm not sure I'm going to get it right. But one of the focuses of the work that we've been talking about is rare variants and how they cause familial diseases, FH and BRCA1 and 2 and what have you. And what we're also learning is that the carrier states are much more broadly distributed than we used to think, and the phenotypic representation of those diseases is not as narrow as we used to think, but is quite broad. And so some effort to understand the phenotypic variation across individual rare genetic, so-called rare genetic diseases, what Lisa is fond of calling empirical OMIM, is another audacious idea that we sort of need to think about, sort of the full representation of what the phenotypic manifestations of genetic disease are.
Lisa, is there anything you want to comment on that?
Using the tools that Mark has outlined and that Lisa has developed, and you better fix me,
Dan,
Lisa.
you did a fantastic job describing that, better than I would, so thanks. I have nothing to add.
Okay, so then we'll move on to the next question, and then just to let everyone know, after we go through all of these interactive responses, we're going to summarize what we've talked about for the last day and a half, and then we're going to ask you to start prioritizing things. This is not going to be your last opportunity to talk about these ideas.
Great, thank you. So these next questions was around those three buckets about foundational resources, breaking barriers, and audacious research goals, and whether NHGRI should be involved to improve genomics in medicine and health in the next 5 to 10 years. So the options were from strongly disagree to agree. And for the most part, most folks agreed that we should be involved. So I'm just going to briefly go through each of these, and you'll see that most folks agreed. So here's for breaking barriers and audacious research goals. But if you compare all three of them together, you'll notice that most folks agree that we should be focusing on foundational resources. And so I wanted to just unpack that a little bit and see if folks wanted to comment on foundational resources versus breaking barriers and audacious research goals. Yes, Malay?
This is more a question. For both these questions, I do see strongly disagree. I'm curious to see where the strongly disagree comes from.
Would anybody like to comment?
It is one person, I believe.
Yeah, so we're not going to force people to like out themselves as being that one person who said strongly disagree with anything. I think part of what we really wanted to be able to see here was, does there seem to be any places here that people feel more strongly that NHGRI should be focusing over others? And are there reasons why you really are excited about those areas? So it does seem like people are slightly more in favor around seeing, NHGRI being involved in some of these foundational resources over others. And so we just wanted to see if there was any real difference between those activities. So it looks like we've got some hands now.
Go ahead, Mark.
So this question was asked outside of the context of resources, and sort of presumed the idea that you had infinite resources, which Terry continually reminds us you don't. So I think that this really has to be balanced against opportunity cost. And the issue with foundational resources, as you're well aware, is that it's a fixed, increasing sunk cost that takes away from the research agenda. And NHGRI, to its credit, has taken on some things like CPIC and that are critically important for the for organizations like ours that are interested in doing it. But if you are looked upon as the only repository for these types of foundational resources, it's going to take away from your research mission. So I think the key for the strategic planning is the balance of how much can we reasonably put into foundational resources before we begin to compromise the primary mission, which is one of research.
Katrina?
I guess this result surprises me because I would expect the audacious research goals to have been the highest. But I guess I would say that the reason that for me the barriers was the lowest priority is because I felt like a lot of the barriers that we were talking about today are not really the responsibility of research. And are more the responsibility of the clinical systems. And so that's why I put that as a lower priority. And I think that foundational resources are something that will be able to help everyone.
That's interesting.
I think that's a great point. And something else that I'd like to pose to everyone is, are there certain foundational resources that people feel would be necessary in order for you to be able to really approach those really audacious research projects? Are there things that you feel like you need for genomic medicine to exist in order to be able to study implementation more? We talked a lot about really trying to move from this area of diagnosis and evidence gathering into more of an implementation and outcomes space. Are there certain resources that you would really like to see in order to be able to support that? Okay.
ClinVar-like or better database of variant classifications that is better in that it involves more sharing and is more robust so that we can actually interpret the results that we're trying to get back to people in implementation. A bank of validated measures for outcomes that are meaningful to all stakeholders in the healthcare system, but most importantly, patients, people, consumers. I'll stop there.
Juan, and then Heidi.
Another resource that I think would be valuable is, all NIH-funded genomic data being sort of accessible, not just in a way that you can just download, you have to download it, but that if you could actually, through some online system, analyze the data directly, such that, institutions that don't have the computational resources, to analyze, let's say, download all 1,000 genomes data or other data sets, or there are in the thousands of genomes and several hundreds of terabytes up to petabytes of data. If they could have that enable that capacity for, so that we have a greater diversity of the actual researchers doing the analysis of the genomic data.
Thanks.
So on the improving ClinVar theme, one of the barriers that's happening right now is that even when labs are willing to share their data, it's an enormous process to get the data into ClinVar in terms of manual export, cleanup, submit, and they often only do it once a year, and then it takes a half a year to get in to actually be posted. The data is really out of date, and so developing like foundational infrastructure so that it is an API-based representation of a clinical lab's database directly from their data so that it's real-time accurate, reduces the workload on their end, which makes it more likely the data will be shared, and then possibly in the future, richer data sets could actually go in where we actually start to get phenotype data, which is a little challenging because clinical labs rarely get that from physicians in robust ways, but perhaps there's a way in the future to actually connect to the originating order, not from the clinical lab, to connect the actual ClinVar entry with the cases from hospitals where they came from.
Good.
From the implementation standpoint, we spoke quite a bit about CDS, but unfortunately, CDS for the most part is the realm of the EHRs. They are the ones who develop CDS. Maybe the model could be slightly different, where we could have something like an app store where private parties, developers, open source developers could develop CDS applications. Particularly if there is a common data model, developers could capitalize on that and build these CDSs, which could then be used by anybody, instead of making it the domain of just the EHRs.
Go ahead, Dustin, and then Amit.
Can I comment on Juan's comment? I agree completely about that need. Maybe it's inappropriate, but I've placed my faith in the Anvil project, and I'm hopeful that this will allow us to bring the compute to the data instead of having the expensive cost of storing and moving the data around. So I absolutely agree that a resource that does that, whether it's Anvil or something else, is essential.
So we have Amit and then Bob.
Yeah, a lot of folks were very interested in foundational resources that link genomic data to clinical data. And at least in America, the vast majority of that genomic data in those contexts is not funded by NIH, but maybe a few different various industry partners around the country. But in aggregate, that's like over a million people, let's say, ballpark right now. And so I guess my question is there a way for NHGRI to incentivize data sharing of those currently existing resources within the confines of those academic partner industry relationships?
So you're looking for a way to be able to make sure that more of this data gets shared in ways that are accessible. So potentially either building ways that information could be linked to one another, or potentially a lot of resources have taken the tack of trying to have the patients themselves share some of that information. But we did talk earlier about how that then ends up putting a lot of the burden on the patients to be able to share the information rather than the system itself. Yeah, Heidi?
Can I just respond to that? Because this is actually the model we used for ClinVar early on. My first U24 or U41 grant actually paid the bioinformatics teams at the clinical labs, the commercial labs, to figure out how to submit to ClinVar and create the workflows and the processes and the time for people to just manually work on it. So the question is for genomic data sharing, let's say from commercial pharmaceutical companies, to understand what the barriers are. Is it willingness, or is it actually just figuring out how to do that and the infrastructure to do it? Because if the latter is the barrier, that is something that could be invested in to help them share it, as long as they're willing to, right?
Bob?
Yeah, just to expand on the ClinGen, ClinVar on steroids idea is that from my viewpoint, that the goal is to recoup resources that are being used to spin the same questions in many different places over and over again. In other words, there's a lot of duplication of effort. And if we could find a way to have an authoritative reference available for many genes and many variants, we could eliminate all that duplication of effort, much of it, and that extra time could be put to doing research.
Latrice, did you have a comment that you wanted to make?
I do think that while we're talking about building foundational resources that are going to tie genomic data to phenotypic data, it's really important that we embed that with LC research and really make sure we pay attention to consent, and especially consent within vulnerable populations, because I think certain populations may not understand, and currently this landscape is moving very fast. So it's really important that we understand and people understand what's happening with their data. And also in the consent process, it's usually a part of the format that you have the ability to withdraw at any time. And as data is moving around these resources, we really need to make sure that we can hold true to that and what it means to really scrape somebody's data from this system. And so we just need to be very cautious and thoughtful about that.
Go ahead. We'll have one more comment.
this is so audacious, I feel like I shouldn't even say it because it's not remotely feasible in 2019. But similarly, a database of penetrance estimates when ascertained in different settings.
Okay, great. Okay, I think so we'll move on to the next set of questions. So our last two questions, should NHGRI be involved in research for training healthcare providers for genomic medicine? And then the second question was for therapeutics. We heard some variation in the community, and we definitely heard some perspectives over the last day and a half. But I really just want to point out and see if we can unpack a little bit more is we have definitely yes and maybe. So the maybe depends on circumstance, for example, only when partnering with others, such as professional societies. So I wanted to ask the audience your thoughts on the maybe, what those circumstances would be. Again?
Going back to my earlier comment, I think when we talk about genomic medicine broadly, we need to understand what that looks like in action based on one's professional position or status or so forth. For example, going back to RNs versus nurse practitioners, one has prescribing authority, one does not. So I think for that reason, it's with the NHGRI having a broader interest in genomic medicine, I think the NHGRI should hone more in on working with professional societies that would be able to tell the NHGRI, hey, within our society, this group of people do this group of people do that, and therefore we would like to tailor our research, our training curricula around that.
Yes, Katrina.
So I just wanted to give an example from our CSER program where we're developing a training for interpreters to work with genetic counselors in doing the counseling session. And so as part of our research study, we're developing that training as well as evaluating from both the counselor and the interpreter and the participant's perspective how that interpretation or how that counseling session went. I think that makes sense to do that kind of development and evaluation as part of a research program, but then to disseminate that if we're successful to more broadly to other interpreters, I think that is not necessarily the responsibility of the of NHGRI. So I think it would be very valuable to be partnering for that next step to get that training program uptake into other systems.
Yes, in the back, Josh.
Recently, some colleagues of ours in Texas got a CPRIT grant to train genetic counseling students as cancer navigators. And this will be a template potentially or a model for expansion. And the two training programs in Texas are participating in the development of the modules, and hopefully it'll be something that can be more broadly disseminated once it's completed.
Was there another question back there? No. Okay. So it sounds like there are some examples of where we can partner either with a professional society or organization for training healthcare providers. So the last question, should NHGRI be involved in therapeutics research for genomic medicine? Again, you see that split of yes and maybe, and that maybe depends on circumstances, for example, only in developing generalizable strategies. So again, just wanted to see if the group had anything to comment on the maybe versus the yes.
And I would say especially here, we had a theme yesterday where we were talking about prevention and therapeutic strategies, and a lot of what we ended up discussing was talking about the real importance of consulting with communities and individuals about what do they really value for their health in order to be able to make an impact, and that in order to make sure that these therapeutic and preventative strategies were going to be useful, that we needed to understand what the community and the participants themselves wanted to be able to get out of the actual intervention or health activity itself. And so here I think what we're trying to do is just dive a little bit more into the therapeutics piece of things. We've talked a little bit about the prevention side, and there seems to be some interest in moving from diagnosis towards prevention. What do people think about the role of therapeutics, and are there goals related to genomic medicine that we should really be thinking about that are going to need to be addressed in the next 5 to 10 years?
I guess when I think about this word therapeutic, it has many different connotations, but maybe one of the areas where NHGRI could lead is, one, creating the actionable genome, at least giving us the tools to which we can apply in the clinic interventions that would be eventually therapeutic, but also to understand the whole process of decision-making at the level of the provider as well as the patient to actually be motivated to take action with this information in front of them. Because I think that's oftentimes where everything just stops.
Thanks, and Dan?
Perhaps with somatic tumor testing, where it kind of spans the non-inherited and the minority of cases that are being detected as germline, and working with oncologists and other team members to figure out how to manage and handle those, because it's both on the therapeutic side, but then also on the germline side, incidental finding, if you will.
Yes, the other Dan.
So in part, this seems to me that this area is under NCATS and not necessarily under genome. But on the flip side of that, it seems to me that NHGRI has in the past and should continue to take the lead in at least therapeutics for rare diseases where there is no market for a pharma to do it. And if they're not going to do it, who's going to do it? NHGRI should take the lead there.
Thanks. Any other last thoughts there? Yes, please.
Yeah, I was just going to add that from what we discussed yesterday, I think the other part that's an opportunity for NHGRI is making sure that when we do this sort of research that it applies to everyone. So as I made that example yesterday with the siponimod approval, if we do have research that has therapeutic or pharmacogenetic guided recommendations for certain therapies that are only applicable to certain group of population, I don't think that helps with our implementation for all, for genomic medicine. So we should try to focus on therapeutics research that applies variants or genetic variants that are predominant in some of the underrepresented minorities as well. And I just wanted to stress that as an opportunity for NHGRI.
Thanks. And Juan, you had a comment as well?
Yes. So one aspect of therapeutics research that we could possibly have an impact on is the selection of participants for clinical trials. So if we can have some sort of characterization of the genomics and the diversity of those populations that are being used by pharmaceutical companies, in determining if a medicine is effective.
Yes, in Latrice.
Yeah, I would also think that LC research on gene editing would probably be important to see move forward.
Okay. So I think we can move on then, and now we'll be switching over to looking at the barriers and opportunities that we were considering the same questions from yesterday, but seeing how these have changed over the last day and a half. And here, when we looked at the barriers, once again, obviously we ended up with the lack being in the middle, but we did notice some real changes from what we had seen at the beginning of the meeting to now in things such as, rather than just focusing purely on the evidence side of things, we had a lot more responses that were talking about outcomes, and that rather than having the focus being on there being a lack of evidence, that people were looking more at it now as there being a lack of outcomes data and really needing to focus more on that aspect of integrating into care. Also saw that electronic health records was coming up more. We had a lot of discussion yesterday around the role of electronic health records and how being able to utilize them and develop tools for being able to use the electronic health records could potentially help with overcoming some barriers of access and being able to have that data available. And then another piece that we really saw coming up is yesterday the infrastructure had really been dominating a lot of the words. And now we start seeing things around more like training and engaging and diversity and showing up a little bit stronger than what we had before. And we had a lot of discussion that was really around how can we integrate and bring teams of people together and really wanting to overcome some of those barriers around access and diversity in care. So any comments about the barriers or changes that people had in their thoughts over the last day and a half? Okay, and then finally, we have our opportunities. And in this one, we also saw that there was a real change from initially really looking at this as being much more focused purely on the clinic and trying to be able to determine how to be able to use this information for being able to make decisions around diagnosis and care, to seeing more of a highlight around prevention. We also definitely saw that some new words that were showing up that hadn't shown up previously were things such as developing app tools, such as what we were talking about last time, this idea of building things on top of the electronic health records to be able to make it easier to utilize the data, that might be a real opportunity. And as we were discussing earlier, this idea of longitudinal data and being able to use that more long term really came up and hadn't been seen when we had been looking at these opportunities on day one. So any comments around the opportunities? Yes, Mark.
I think the other difference that I notice, given that I was specifically looking for it, was the enhanced prominence of patient in both barrier and outcomes, which is interesting other than the fact that barriers and opportunities are frequently two sides of the same coin. But I think this does reflect a lot of the discussion that we've had about the critical importance of the patient in this whole exercise. So it was gratifying to me to see that.
I think that's a great point. And you can also notice just by looking at this word cloud, when we did this activity on day one, it was pretty much like genomic medicine was the big thing that stood out in the middle. And then there were less words that were around that, and now you're seeing a lot more different ideas that people are thinking of for opportunities that had more even weight. So we definitely are going to go through all of the results that everyone submitted and parse out some more from the individual data and responses, because it does definitely seem that over the day and a half, the different opportunities that people are thinking about have become more diverse. Any other comments around the opportunities? Okay, then I think we will move on then to summarizing the information that we've had over the last 2 days. That'll be in the next talk. Okay, so we'll pull up those slides real quick. So now what we're going to do is we're going to just basically summarize the information that we've heard on the 6 themes over the last 2 days, and then get some comments and feedback from you around where should we really be prioritizing. Thanks, Jyoti. So talking about recommendations and priorities is our ultimate goal here. And I wanted to start off with the vision statement that we had started with at the beginning of the meeting. So we started with this vision of really trying to integrate genomics into routine medical practice in a way that was going to help with preventing disease and really improving health in all members of the community. And that we wanted to do this by engaging the patients, their families, as well as the entire healthcare team in genomic healthcare. And so this is the vision that we started off with at the beginning of the meeting. And the first thing we wanted to do was open this up and ask everyone, does this seem to still represent what we've talked about for the last day and a half? And is there anything that people feel needs to be added? We're not really looking for, exact wordsmithing, but are there major concepts that people would really like to see added to this vision that we're missing in its current form? So any comments on the vision? Yes.
In the vision statement, you mentioned specifically patients and their families. The unit of the community is not called out, and I think that would be, although incorporating those individual units, a larger unit of analysis that you might consider including.
Thanks. Any other comments on the vision? Okay, so then we'll run through each of the themes. And here what I've done is basically start with just the theme and the question that we started off with, and then the bullets are all new based on our discussion over the last day and a half. So starting off with theme 1, we talked about being able to create systems that were going to integrate genomics into routine medical practice. And here we were really trying to get at what is going to be needed in order to be able to use genomics in medicine and health. And some of the items that we heard from our discussion was that we really need to be able to take responsibility, to be able to engage diverse communities, and that this is going to really require there to be a change in the system, and that though NHGRI should not be responsible for changing the entire healthcare system, that we can really think about how we set up research studies to be able to make sure that we're engaging all of these communities from the start, and take responsibility for making sure that all of our studies, when we're thinking about genomic medicine, are thinking about the broader community context. Another point that we heard here about systems was really trying to develop infrastructure for data portability. And here we heard that data needs to be portable so that we can continue to use it over time, and that we also need to really think about using this data in flexible ways, that different communities and different individuals might want to use the same genomic information to be able to get to different endpoints, and that we need to make sure that any systems that we develop for genomic medicine are going to allow for that use of the information in different ways by different people over time. And then finally, the third main point that we heard come up was really the ability to test implementation strategies and develop best practices. And this once again gets to the idea of, now that we're starting to think about how to be able to have bigger systems to integrate genomics into medicine and health, that we need to really be looking at all of the different implementation strategies that are being tested and compare them, look at them, see what works well, what doesn't work well, and then be able to use that knowledge from people doing lots of different kinds of testing of implementation to be able to develop better practices for the community at large. And so those were 3 of the main points that we heard really come out of the discussion from theme 1. And I'd like to open it up now and see from you guys, is there anything that we're missing in this summary here of main points around systems? Yes, Jeff.
Around the third bullet, I just wanted to make the point that not all implementation of genomics is taking place on the heels of NHGRI research. So we should try to engage the communities of healthcare delivery systems that have just taken the initiative on their own to incorporate their best practices into our thinking. And the other community that actually has a very strong interest in implementation is the genetic testing company community, the industries that are trying to also implement, so that they have different motivations, of course, financial, but they are running up against the same barriers that we are and have to generate the same evidence that we're talking about. So there may be some opportunities for us to partner with them.
Great, so really make sure that we're considering partnership in those testing of implementation strategies and development of practices. Anything else that people would like to add to this summary from theme 1? Okay, so then moving on to theme 2. So for theme 2, we focused then more on the test itself and how can we improve genomic testing to be able to make it routine, high value, and easy to use. And some of the points that really came up from our discussion yesterday was that we really need ways to be able to communicate next steps clearly. And this came up both in the context of the actual patients themselves, as well as so that the providers and individuals in the healthcare system have information that's being returned to them in a way that makes it very clear how they could utilize that information versus just receiving back, for example, a PDF report. There was a lot of focus on being able to make sure that this could be utilized in diverse clinical settings. And one of the solutions that came up was this idea of thinking about the electronic health record, and are there potentially ways of being able to build apps or other structures on top of that that we could utilize for being able to make sure that the information that's returned has some more information regarding how those data points could be used clinically and what the next steps are for care based on the genomic results that are being returned. A second major point that came up was really trying to make sure that those results are then comprehensible. So not only providing the next steps back to individuals, but making sure that we're actually looking at behavior changes and outcomes. Did we make sure that that information was easy to understand? Did it lead to changes in behavior? And what were the outcomes or changes in management that occurred because of that result being returned? And then finally, a third point that came up in a number of the talks in this session was the idea of dispelling discomfort. That there was still a real sense that in the clinical community, there are some of these return of results situations that people just feel very uncomfortable about, whether that be because the information isn't necessarily as clear, or that people don't feel as comfortable about the actual data itself and what its utility is. And that we need to work on developing ways to dispel that discomfort and make the information more accessible in order to be able to really promote adoption. And so those are three of the main messages that we heard come up in theme 2. And I'd like to open it up now for anything else that we missed in this summary. So any comments from the audience? Yes, Bob.
Just had a thought. So this comes up sometimes in the clinic that, we do a gene panel and it comes back negative. And so we said, we didn't find anything. But actually what we found was that they didn't have evidence of a number of disorders, which is a positive result. And I think that often gets missed in our communications about the value of these tests. So we didn't find the answer to the clinical situation, but in the context of the population-based testing, the public health testing, asymptomatic testing, it plays a bigger role. So I think being able to learn how to communicate that piece of information is important as well.
So it sounds like you're talking a little bit about communicating negative results beyond just the results from the testing.
So, no, I'm just saying that the negative results actually have value. So you say, well, we didn't find anything, so it was useless. It wasn't useless because we know that you don't have the common mutations for hemochromatosis or other things that are relatively prevalent.
Okay, so I definitely got a lot of comments on that one. So let's go with Megan and Mark and then Colleen.
This is just related to the other things that I heard in theme 2. CDS systems came up a lot, and they're implied here, but I just want to call them out specifically. And then the limitations of CDS and their potential discriminatory power given the data inputs that we have.
Thanks. And Mark?
It's possible this will be captured in one of the other themes, but to me, this doesn't reflect some of the discussion that we had about reuse, reinterpretation, reanalysis, and longitudinal use of data generated from a test. That needs to be captured somewhere.
Yes, and I did try and make sure that the bullets were not necessarily overlapping, though a lot of our conversations were. So we'll definitely make sure that that context of longitudinal data also gets captured. And Colleen?
Yeah, I think that the third bullet point on that slide, track comprehension, behavior changes, and outcomes. I think beyond track, I think we know very little about how to ensure or enhance comprehension, behavior changes, and outcomes. And that is absolutely critical to this theme. And sometimes we look over that too quickly and just look at the testing itself or other kind of forms of implementation research like adoption, opposed to, do we actually know how to talk to people about this and get them where we and they want them to go?
That's a great point. So beyond just recording, did we look and see if people utilize this information, but trying to understand the best ways to convey the information, how can we improve the process? Great. Okay, so Dan, and then we'll go to Jillian, and then Heidi.
Colleen's comment made me think about what I was going to say in theme number 4, which is things like models of delivery, like motivational interviewing, and how studying those different models and techniques of engaging with patients may or may not lead to improved behavior outcomes and otherwise.
Great. Okay. Jillian?
Yeah, I think when I was looking at this slide, I just started playing with some of the words on the slide and thinking about how would it be different if it was improving processes for routine high-value clinical genomic diagnosis, that the test is sort of a tool in the diagnostic process, and then thinking about the communication processes to establish the subsequent plan, the care plan for that, which then sets you up for the outcomes that you want to measure. So thinking about these sort of groupings almost, it's like bundles of services which include the test, which include the person who's delivering it, and how that sets you up to achieve the outcomes that we talked about.
Great point. And Heidi?
So a few different things here. You know, I think one, any test we run is not 100% sensitive, so it's difficult to say that you've ruled out anything. But I think developing the framework to be able to more accurately state that based on what the test is capable of is, you know, half the disease caused by an inversion that's not detectable by your exome sequencing, so that when you say it's negative, have you taken that into account? And we can actually build knowledge bases to define the contributions to each disease or indication that might help actually, you know, define what you did and didn't rule out, and your confidence in that, and whether there's another test you should order.
You went out. Oh, there you go.
Whether there's another test you need to order before you can say, you know, and sometimes it might be starting with a genome and reflexing to panels and other tests. And I think helping create a knowledge base to support that, which then also feeds into the reports that physicians can hopefully understand and know what the next steps are, would be, I think, very useful. Also, there's very little standards in genetic test reports, which make it very difficult for anybody to understand them that's not an expert. And so I think developing really good guidance and templates and things to help the clinical lab community, you know, decide what to put in a test and how to explain it and point to other resources, I think that's a whole area that really has not been supported well.
So really diving into some of that idea of making things easier for people to understand and comprehend through developing standards that would be more comprehensive across the types of clinical reports that would be returned. And so Carolyn and then Lisa.
And I mean, I just picking up on what Heidi said, because, and again, we all come with our own biases, so I'll just ignore that. But if you think from a technology perspective or a technology development perspective, I think there's still not great. It would be good also to get the communication of what are the things that current tests aren't capturing that we would like to have tests for. You know, I mean, that's part of it, right? But then what are, you know, how do we sort of address that issue is something that I think is, and Anastasia and I have talked about this, but getting that two-way communication as well, so that the people who are doing the sort of technology development are understanding what the clinical needs are.
100% agree.
Okay, Lisa?
Addressing what Heidi, you just brought up, I think it's really, and based on a conversation I just had with Les, it would be really interesting to move into a more probabilistic form of integrating the information you get from a genetic test with the whole clinical picture of a patient. I know this is a really kind of grand vision, but if somebody has a strong family history for cancer, let's say, then they have an increased probability of, let's say, getting breast cancer. A negative cancer panel will lower that probability. But what Heidi is saying, it's a really good point. It doesn't eliminate the possibility that they actually still carry a high genetic risk. So thinking about ways that we can integrate both the phenotype and genotype information together to come up with a probability to predict the things we want to predict would be a really interesting way to move forward.
Great point. We definitely had a lot of discussion yesterday about this idea of trying to integrate the information that might be in a clinical record from other sources along with the genomic information in order to be able to try and improve those risk estimates as well. So Dustin?
Yes, I'd like to just draw attention to a point that was made in Michelle's talk from Rady about the bleeding edge of genomic testing. I just don't want us to overlook that right now our tests are good at some things and not good at other things, specifically structural variants, short tandem repeats, regulatory regions, and so forth. I just think that's important to capture that as well.
Thanks. any other comments about theme 2 focused more on the genomic test itself? Okay, so then we'll move on to theme 3, which was around building knowledge bases for predictive genomic medicine. And what do we need to be able to tell any patient their risk of disease based on genetic testing? And so here we really heard from the presentations yesterday a desire to be able to establish, evolve, and harden standards. And these were all different types of standards, but that we needed to not only consider what should those standards be, but that we needed to continue testing them and improving them as the technologies continue to improve, and then try and make some of those standards into things that would then be utilized more frequently. There was also this interest in improving integration with other clinical information over time that we talked about. And then the final point that we brought up from the conversation yesterday was the real desire to be able to share knowledge and data. And so this came up in lots of different contexts, both the idea of having rare disease data that you want to be able to share more globally in order to be able to have all of that information available, wanting to be able to share knowledge and data with participants, wanting to think about what kind of data, do you want to be able to have from communities. And so this was just a broader point that came up a lot yesterday, this idea of trying to share all of the information that we're getting from genomic medicine in order to be able to improve how this could help the health of everyone. And so those were the 3 main points that we had come up from themes 3's discussion. We've talked a little bit around the standards and the integration, but definitely want to hear if there's other topics that we missed within this area. So Mark?
I think the bullets are fine. I just would recommend semantically using knowledge resources rather than knowledge bases, because I think knowledge base tends to make people think about an Excel file or something, and we're really talking about something much more sophisticated, which is well reflected in the bullets.
Thanks, Mark. Any other comments or adds around theme 3?
I think maybe
yes.
Just extending on what Lisa just said, that probabilistic estimates, all risk estimates are probabilistic, even for monogenic diseases. And then around that, enhancing patient numeracy, physician numeracy about these risk estimates, I think is important when you convey these genomic or even more comprehensive risk estimates.
And having that kind of information accessible in these types of resources?
Yeah.
Okay. Yes, please, Dan.
There's no mention of privacy in that section, and maybe there needs to be an addition of that or some additional verbiage.
So the general concept of the privacy related to these resources and databases as well. Okay, so then for theme 4, Theme 4 was focused around developing and evaluating genomic prediction and therapeutic strategies. And here the question that we asked was, how can health improvements from the use of genomics be demonstrated? And our talks focused a lot on engaging communities as partners and really understanding what the goals are of the community and individuals in order to be able to make sure that genomic information is going to be utilized. And in order to get health improvements, you need to understand what the health improvement is that really matters to the community or the individuals themselves. There also was a real focus on studying dissemination and trying to determine what works, that we need to have studies done in a variety of different communities and populations, because what works in one group might not necessarily work in another, but that overall we need to be able to take and study these types of dissemination projects and then be able to share that information so that others can build upon those lessons learned about dissemination. And then finally, this real idea of sharing those conversations and sharing success stories. There was a lot of interest in the fact that right now, a lot of these projects are done very much separately from one another and wanting to be able to develop ways and resources of sharing how people have been able to interact with their community so that others could build off of this and have successful interaction with communities more as partners in the research as well. And so that's what we had for the conversation with theme 4 yesterday. And comments, it looks like we have one from online.
Yes, we have an online comment, and it may have been from the earlier discussion with therapeutics, but rather than referring to therapeutics, consider using the term management as broader and consistent with clinical attitude, having to tell the patient what to do. Plus, it emphasizes the need for longitudinal follow-up to characterize the clinical history of the genomic disorder.
Thanks. Yes, Mark.
In bullet 1, I think it's important to engage patients and communities as partners. So again, I think it gets to your vision statement where we talked about the different units, and so we should make that consistent.
Thanks, Mark. Any other additions or comments on theme 4? Okay, so then moving on to, yes, please.
Sorry, I'm delayed, just slow. So this came up in our recap. We were talking about the infrastructure, what changes we could make to NHGRI's infrastructure to improve the diversity of engagements that NHGRI is funding. I think that was part of theme 4 yesterday, certainly part of Carol's presentation and part of the comments today that isn't captured here but might be somewhere else in your summary.
Thanks, and I do think that was a very strong message that came out of the presentations yesterday, this idea of engaging communities and patients much more as partners in any sort of research that's being done, and that's somewhere that NHGRI could potentially make a difference, is really thinking about how that could be advocated for more in research studies of genomic medicine. Okay, so then for theme 5, we heard about ensuring that genomics has maximum utility for all members of the public. And here we focused on the question about how do we make sure that genomics is both available and useful for everyone. And the points that we brought out of the discussions were to ask about meaningful utility and people's values. And that the idea here was that individuals might have different values and different ideas of what information is useful for them, for their health. And that the only way that we're going to be able to really understand and address those values is to ask people what it is that matters most to them, and to understand that there might be differences in opinion here and be able to respect the fact that those different patients might have different choices about how they want to be able to make their health choices and decisions. Similar to that, there was this idea of pursuing co-creation with patients and provider perspectives. So this kind of gets to the point that Megan was just bringing up, this idea of really working with the patients and communities and providers together to be able to think about the process from the start of research or a clinical care process through the end, in order to be able to try and develop processes for implementation that are going to be more responsive to patients' needs, as well as what the providers are trying to do as far as a health change or management change. And then finally, there was this point around really needing to have further discussion around the role of families when you're talking about sharing genomic information, privacy, which we touched on a little bit earlier, and the idea of ownership of who actually owns some of this data. There were pieces of this that came up both in the discussion yesterday and today. And so we thought that these were all places that people seemed to not necessarily have a solution, but felt that there needed to be more discussion around how we can handle the role of the family, as well as what do we need to do in order to be able to address differences in privacy decisions and thinking about ownership going forward. And so those were some of the main points that we saw coming out of the discussion yesterday, and would like to open this up for any other additional thoughts. Colleen.
So this is less bringing out things that came up yesterday and more just looking at the words on the slide. I think the maximum utility piece again gets at, how do we administer genomic medicine to ensure maximum utility? And there's a lot of work to be done there and a lot that's unknown. And then the all members of the public, a decent piece of that gets into access and disparities, and making sure that the efforts and research that NHGRI funds is ensuring that it truly is all members.
I think so, really emphasizing some of the language that's there already to make sure that we don't miss the points from the earlier theme and what came up in some of the discussions. Any other additions for theme 5? Yes, please, Rachel.
Yes, I'd like to add, asking about meaningful utility and values. That not only applies to individuals or patients and their providers, families, but also to larger entities, such as companies that also have an interest in either sharing or receiving genomic information.
Thanks. And Ithakar?
I think we need to emphasize, how information is shared within families and how we can improve the yield of cascade testing. I think it should show up somewhere because that's really critical.
Great. Dustin?
I would just like to call out Andrew's point about the army of nurses and nurse practitioners and so forth. That was a really important point that I learned during that session, and I think it should be captured here somehow.
So really engaging everyone in the practice and making sure that healthcare is utilizing broad perspectives.
Yeah, and maybe more specifically calling out the different levels of providers that we may not typically think about. I think when we hear the word provider, some of us jump immediately to MD, and so it might be important to just list out the different categories that we're talking about.
Yeah, and I included that a little bit more under the training piece of things, but I think we should talk about that more and if there's other places that needs to be integrated more. And Mark?
Yeah, to build on Dustin's point, which is very important, I think it's not just listing, but it's matching the specific information to the provider type. So pharmacogenomic information is rightly in the purview of the pharmacist, and perhaps a little less so to the prescriber. Whereas in other situations, there might be other content experts where it would be more appropriate. So some sort of an analysis of how to match the specific information to the specific provider type to take advantage of the just all the disciplines that are represented in the healthcare team.
That's a great point. And I think that starts getting us then into theme 6, where we're really looking at how to train healthcare providers to be able to integrate genomics into the clinical workflow, and what training do we really need for genomic medicine and information to be utilized for health. And so here we really heard earlier today that there's a need to be able to define what some of the skills are for genomic medicine implementation, and then really thinking more about how we can compare and share different methods to be able to optimize training, as well as how that gets implemented and how that information can be supported for different types of providers utilizing this information in healthcare. And then finally, we really talked a lot about engaging healthcare professional teams across disciplines, trying to get into the points that were just highlighted from both Dustin and Mark around the idea that there are a number of different types of professionals in the healthcare workforce. How can we best utilize all of them and have them work together in teams in order to be able to implement genomic medicine effectively? And so I saw Amit.
Yeah, I just wanted to reinforce one point about electronic health records, and I know that there's varying opinions in the room, but like that picture you chose for clinical workflow, right? That's like presumably a provider with two hands sitting at a laptop and with a coffee and an iPhone, right? And that's actually like pretty much reality for clinical workflows in America in 2019. And so I guess what I'm struggling with is like there's so much stuff about integrating into routine clinical workflow, which is like, for better or worse, it's like really dependent on electronic health records integration. And so, I just wonder whether or not it's worth really spelling that out as a key barrier.
So pointing out that the electronic health record is something that we're going to need to work with in order to be able to improve genomic medicine's use in a routine clinical workflow.
I think it's something different, and Amit can certainly argue with me about this, but I think it's really about understanding the workflow of the clinician and putting the information in the hands of the clinician as part of the workflow, so that it's integrated seamlessly as opposed to being disruptive.
So that then builds upon the idea to be able to talk about trying to make sure that people have the information when they need it and in a way that's going to be useful. Mm-hmm. Okay. So then we've got Dan, Bob, I think I saw Jillian, and okay, so we've got Dan, Bob, and Jyoti has a comment from online. Okay.
So just on bullet number 1, maybe broaden that to include competencies and skills. I don't know if that's a semantic distinction, but also that are also discipline specific and or specific to the different provider types and skills we want them to have.
Okay, so thinking about competencies as well. Okay, Bob?
Also the EHR question and my comment yesterday that if we expect the EHRs as they're built and as they're being changed by the EHR vendors, we're going to hit a hard stop. So you may want to change if you include that, change the wording to, health record systems of some sort, so that you can include the kinds of things that Heidi was talking about and the others, and not just sort of perpetuate the idea that the EHR is going to solve our problems.
So just thinking a little bit broader than the electronic health record. Okay. And Jyoti, you have a comment from online? We got you.
Yeah, so this is actually from the last theme. Utility for all members of the public is fine, but is this inclusive of payers, providers, and other stakeholders?
Okay, so trying to make sure that we have those perspectives incorporated in other aspects of the genomic medicine question as well. Okay, and Aniwa?
Yeah, so if we're considering ensuring that genomics has maximum utility for all members of the public, maybe for the second bullet in theme 6, compare and share methods to optimize training for implementation and support in all clinical settings. Because I think earlier we talked about how, most of the primary care are not in academic medical centers and in like ambulatory settings and other things. So maybe having that distinction in the second bullet will help to ensure that we're capturing everyone.
Great point. Colleen?
Yeah, I think when we were discussing this theme, we also talked some about training researchers. And I'm just wondering if that belongs here or if there's somewhere else for it. And there is training of researchers that's part of NHGRI's mandate and that is critical to implementation of genomic medicine.
Yes, thinking a little bit more, especially where we were talking about the teams, we were talking a little bit about that being both within the healthcare team itself as well as bringing in the more basic science research side of things into connections with the clinicians as well. So making sure that we don't lose that point in the summary.
I think there's another classification of researchers, though, that there's implementation science, dissemination science, clinical science, communication science, behavioral medicine, that is all absolutely critical to implementing genomics in medicine and health.
So making sure that we have that connection between the researchers that are working in this more clinical space as well as the actual clinical practice and the training for both.
Right, and that NHGRI is supporting training.
Great, thanks. Any other additions for theme 6? Okay, so we've gone over what we heard from everyone. So now we're going to open up the conversation to talk about priorities. So we have covered a lot over the last day and a half, and we'd like to hear from you now. Are there any of these points that you really feel should be the priorities that NHGRI needs to be focusing on first? So these could be really the activities that you feel need to happen in order to be able to allow further research to occur within genomic medicine. It could be particular projects that you really resonated with. What do you guys feel are really the priorities for us going forward? Okay, Latrice.
I would argue that diversity should be a part of every single agenda item that you set forth.
So making sure that diversity is not lost anywhere as we start thinking about genomics, and so that really becomes a value that we're going to consider in any type of genomic medicine implementation. Great. Yes, Sula.
Clearly I'm biased because this is from my theme, but I would say prioritizing community engagement and public involvement, especially when we think about patients being kind of one of the end users of the information and needing to understand that and working with their clinicians and also utilizing this information for preventive purposes.
So making sure that we engage communities in the research for genomic medicine. Yes, Patty.
And one of the things I heard earlier that I want to be in every part of it too is value, and really have the value of every different stakeholder.
So trying to determine what different stakeholders' values are so that we can make sure that they're addressed because they might be different.
Right. And another thing is communication, to have communication a part of everything that we do as well.
Right. Mark?
Standardization of outcomes across all projects, I think, is important.
Great, and particularly focused on outcome measures for those standards?
Yes, I mean, although I wouldn't necessarily restrict it. I mean, I think we heard about from Wendy about outcomes that can be quantified, but I think also we need to think about outcomes from the different healthcare perspectives, but which need to be on a common framework. So the article that we published between the Clinical Genome Resource and eMERGE about outcomes harmonization is an idea about how both of those groups are looking at, actionability in a similar way, but we haven't defined the outcomes that we're measuring in precisely the same way. And Ignite has done some work, and I think in the Ignite toolkit, there's actually an outcomes definition that's being used across all of the Ignite sites for the projects that they're doing. So those are sort of examples of how, if we were able to expand that early work into something that was transdisciplinary across all the different projects, we'd be able to combine data better.
Carolyn?
So I 100% agree. I'm just going to push on the thing I sometimes get stuck on. So people were talking at one point about, how do we think about behavioral change? We tell someone at high risk and they don't change behaviors. I feel like sometimes we tell researchers the value of standards and they still don't implement them or use the time, or as you said, the whole thing about multiple different standards. So what is it that you think is the most effective? What are the ways that are effective ways for us to really move an idea like that forward versus just saying, wouldn't it be great if we had the standards and could combine the data? Like, what's really needed to make that happen?
What's going to make people use an outcome standard? Megan?
Funding. Yeah, so if you make financial incentives, then it will work. I mean, it will be a forced marriage and no one will be happy, but eventually people will start doing it you all have the money. So.
No, and I agree. But I want you to all remember that when your program director then tells you that's part of what you have to have your money on into the thing of limited resources, that it is sometimes at the effect of others. I agree. I'm not disagreeing. I just want to point.
We'll come back and hold you to it. Okay, so Heidi?
But can I just say, better than forcing them through, well, I don't know if funding forces them, but if we can show that using the standard leads to better research and better papers and publications and discoveries and everything else, that to me is the better incentive, right? That they're actually going to do better work if they can harmonize their data with others. Like, I think in eMERGE, everybody's contributing their plot of patients. The benefit of implementing the same standard phenotypes across all of the groups so that everybody could then get the data from the other groups, and the power of their research was higher, right? So you could very directly see how implementing the same standardized phenotyping algorithm would lead to a better, discovery and correlation. So to me, that's, trying to figure out, like, what's the end goal and why do we create standards, right? It's to be able to share, compare, expand what we're doing, but we have to really make it clear how you're getting there, right?
So the positive side of things and trying to show off the positive impact of being able to have a standard and the value of having that information accessible. Jillian?
I think the other thing that's come up a lot within the National Society of Genetic Counselors is we've thought about standards for outcomes data specifically as thinking about future payment models for the profession that are really going to support the clinical workforce, and increasingly payers and other reimbursement models are thinking about how do you prove quality, how do you prove outcomes, and if we're going to have to do that as a field, we're going to have standards for how we define that, so it's really critical.
So it's kind of a little bit of combining both the funding aspect as well as the value aspect of the previous points. Okay, so I saw Colleen and Bob.
Jillian stole it.
Okay, so Bob.
Yeah, and just sort of expanding on it, and to sort of push it to the end, is that what we want is clinical utility data. And so all of these things that we've been talking about sort of support the infrastructure to put out quality clinical utility data. And you can take, the example of pharmacogenomics, and if you look at anything beyond the most recent literature, before that, the quality of the studies is terrible. So that's really what we're shooting for, and that could be, facilitated by standards. It could be facilitated by the infrastructures, and a number of other interventions we've talked about.
So far I've heard a real push for diversity, a push for including communities within these conversations, and a lot of conversation around how can we build standards to be able to improve our ability to be able to do research within genomic medicine and improve clinical care by having that information available in a way that it can more readily be used across different studies. Are there other things people think are priorities? Yes.
So I think it's really important to recognize the lack of awareness across the country of genomics, both within the public and within the providers. And that is a huge barrier to all of this integration. So, excuse me, Buffalo's not a small town, but it does not have the coordinated health networks and academic centers and hospital networks that are present in other places. It does not have some of the depth of knowledge. We have medical students, so I'm in the medical school, we have medical students who do not want to be taught pharmacogenomics because they don't believe it's relevant and it's not on the boards. I mean, there's a fundamental lack of awareness of the importance of this, and I think that has to be a priority in increasing that awareness.
So is that more of a push for messaging about getting the information out there about the value of some of this information that is ready for implementation?
Yes, it's awareness, it's about the value, it's about what the resources are and how to use them, that sort of thing.
Great. Latrice?
I think the messaging could be greatly enhanced with partnerships with the AAMC or AMA or the different medical associations, rather than trying to do a grassroots effort for it.
Great point. So in order to be able to get this word out, try and find different professional societies and groups that we can partner with to be able to make sure that that message gets out to their communities that they already have the networks to reach. Okay, Dan?
I don't know that this fits anywhere, but the last 2 points make me think about, right now, the agenda is being driven by 23andMe, Facebook, Ancestry.com. We need to do some type of marketing and or education in the public forum in a way that I don't think is currently being done, because people are getting messages that are inaccurate, inappropriate, and misleading.
So the public message about genomic medicine. Yes, Jeff?
It seems to me a priority for our agenda should be to make genomic medicine something that NHGRI doesn't necessarily have to pay for forever. So right now, all of our genomic medicine programs are being sustained by the NIH for the most part, but how can we build research programs that really establish the value proposition so that the healthcare delivery systems and or the payer communities, which are very varied, will actually help sustain it. And that means really bringing payers and economists probably to bear on a lot of the work that we do.
So trying to determine what's needed to be able to move more from research in genomic medicine to actually having it implemented in a clinical setting where it's actual standard of care.
Yeah, well, where somebody recognizes the value such that they're willing to pay for it outside of a research program.
Great. Yes, Mallory?
Just adding to the standards, it's not enough if the research community follows the standards. There needs to be some leaning on the EHRs and the diagnostic labs also to adopt the same standards.
So actual clinical standards that you can have that connection and communication between the research and the clinical side of the data?
Yes, exactly, for interoperability.
Great. Any other thoughts on priorities for us? Okay, so that brings us to the end of our discussion so far here today. Les, is there anything else that you want to be able to add to the end of our priorities discussion here before I turn it over to Eric?
Sure. Hopefully I won't overlap with what you think. But I think to the extent at which we accept that vision, I I don't know how you could come to any conclusion other than that is a gigantic beast of a problem that probably needs an order of magnitude more solutions even than we potentially came up with here today. And well, I'm getting to that. I'm getting to that. And so I think what it's a predictable but a great outcome of this group is what we did here quite deliberately was gather a very diverse group of participants in discipline, in background, in career stage, and we got a very heterogeneous bunch of suggestions, all of which have potential value. And so I think what we have here now in front of us is an amazingly diverse palette of opportunities that we could pursue, you could pursue, and I think I didn't hear a thing that must be done to reach that vision. I heard 1,000 things. And so I think what I'm thinking of this as raw material for the Institute to take back into the strategic planning process where you all then get the opportunity to integrate that with costs, tractability, overlap with missions of other institutes, overlap or complementarity to the other thematic groups that are part of the strategic planning process, and download, pick and choose from this palette things that make sense with all those other considerations. So that's sort of my takeaway from that, and be happy if anyone feels that I missed the thing that we must do. So that's what I would say. So thanks.
Great, and I think that is a really nice summary that one of the things we have heard time and again over the last day and a half is just how important diversity and the fact that people are going to have different perspectives and we're going to have different settings that we need to work with and we have different providers and disciplines that we need to bring together, that does seem to really be one of the themes that we heard from the meeting over the last day and a half, is that we have to respect the fact that there are going to be potentially different answers that work in some of these different settings and for different people, and that we have to build a system for genomic medicine that's going to allow us to be able to leverage that diversity and make it a better care experience for everyone, rather than trying to fight everything into being able to do one process for all. Okay, so we'll turn it over to Eric.